So thank you for having me here. As it has been said, Dr. Shapiro couldn't be here. I've been seeing a Degos patient with Dr. Shapiro since 2009. Briefly, I met him when I was on call, and Dr. Shapiro called that he was transferring a patient over for IVIG treatment. Be ready. So I was ready for the unknown, and he wasn't responding to IVIG. He was decompensating. Just a brief history of where I fit into this. And so Dr. Shapiro and I started reading a little about Degos. Neither of us knew. Dr. Shapiro has a wide scleroderma network. He knows a lot of people. I remember he trained me, and I remember one of the things I learned from him is that a good physician not necessarily knows it all, but a good physician may know people that may help you find a way to help your patients. So he sent a message through his scleroderma network, and a physician answered, which led us to Dr. Magro, eculizumab, and I think everybody here knows the rest of the story. So I've been seeing the patient since 2009, and we've had ups and downs, but in general, he has been doing very well until recently, where he's presenting with these kind of like scleroderma type of presentation, a lot of fibrosis. All right, so having said that, I will use his deck. He prepared this, and I think it's appropriate for me to use his work. He doesn't have any, I don't have any disclosures. These are his disclosures. So whom should we treat? These are questions that we don't have answers to. All individuals with cutaneous disease, should they be treated, and how should they be treated? Asymptomatic individuals with Degos disease, with evidence of visceral disease, and how we're going to identify these patients. There have been some conversations today about laparoscopy and other imaging modalities. Hopefully we can come with some answers in the future. Or those with symptomatic visceral disease. So symptomatic versus asymptomatic, hopefully we'll know who to treat, how aggressive to treat. Is anyone too sick to get treated? And I actually have this question right now with my patient, which how aggressive, what's the next step? He's already on eculizumab, he's already on treprostinil. Should we add a JAK? Should we add sirolimus? Where to go from here? There have been some barriers to treatment. There has been, as we know, late diagnosis because it's a very rare disease. We should make awareness of the skin findings. Once we see these papules, we will always be able to recognize them. They're very unique. But most often, as we've heard all throughout the day, they have been ignored or misdiagnosed. Or sometimes they are late appearing, or they don't appear, which is the rarest of the rares of the cases. These patients can have multi-organ involvement. We've seen that in the literature. Most of them, the number one cause of death is sepsis, usually from GI perforation. They do have impaired gastrointestinal function, and I do question with my patient. There was a time that when treprostinil came out by mouth and we switched him, he wanted to use by mouth medication, and he was on it for a while, and I do wonder if that was the time that he was getting no treatment at all. Could that have contributed to what's going on right now? So they do suffer from malabsorption, and they can have irreversible neurological deficit. And my patient has had some reversible neurological findings after the addition of treprostinil, but it happened while he was on eculizumab. There is unfortunately delayed access to drug, so eculizumab has been very difficult to obtain by some patients, and maybe it has been given when they are very advanced. Also, the need to obtain insurance approval. For me, I was able to get the RBI approval relatively quickly because it was the second patient who had the eculizumab. So we got the medication very quickly overnight. There was a storm, and once he got the medication, it was like a miracle. He did responded probably because it also suppresses anaphylaxis, so the C5a suppression, I assume, was playing a role, and he had a abdominal compartment syndrome. His abdomen was partially open with his bowels partially on his external, and after that he was able to be closed. And in the past we used to get it by compassionate use, but I believe that's not the case anymore. We've talked about the cost, so we already know these are extremely costly medications. Where to go from here? How are we going to address the treatment? Should we address the microvascular disease, large vessel disease, obliterative fibrointimal arteriopathy, deficiency in angiogenesis, fibrosis, especially what I'm seeing right now, the pleura, the serosa, the pericardium? Should we continue to address complement activation? Should we do a combination, triple therapy, like we do with my patients, rheumatoid arthritis? We use triple therapy. Or 4 at the same time. One thing, retrospectively thinking now, that I think the sooner we start medication, this is my personal opinion, the better, because if the patient is advanced and then we hesitate because of the risk of infections, if the patient was healthier, stronger, maybe he would tolerate the JAKs, the sirolimus, and these other medications. So should we add antiplatelet agents? We were talking about the statins and how they can even play a role suppressing macrophage and fibrosis. Anticoagulations, I think they should all be on anticoagulation. Steroids. More often than not, in the literature that I've read, that I think I've read every single article out there, like most of you have, patients who have been exposed to steroids have perforated. I know there are some that haven't, but what I've seen is that more often than not. So I've been very hesitant. My patient has never, my patient and Dr. Shapiro's patient has never seen steroids. IVIG, I was there, I saw it, in my patient it didn't work. He decompensated while using it. There are multiple medication failures, cyclosporin, azathioprine, cyclophosphamide, methotrexate. They all have been tried. So what is our eculizumab experience? We used it mostly based on Magra's literature and experience and her research, suppressing the C5b9 deposition in the microvasculature, in the skin, in the gastrointestinal tract, and associated with endothelial cell injury and microvascular thrombi, so it may suppress all of this. As I already mentioned, it also inhibits the C5a, which I think it's what causes that miraculously immediate response, and then on a longer or more chronic setting, it suppresses the apoptosis by the C5b9 suppression. So I first used it in 2009 with my patient, who's the second patient on eculizumab. So the patient number 1 is a 46-year-old man with a previous 3-year history of characteristic skin lesions, episodic abdominal pain, and a recent bowel perforation, adhesions, and obstruction. In the medical ICU with pleural pericardial effusions, cardiac tamponade, a pericardial window was performed, different from my patient who never had any partial serosa or pericardiectomy. So a lot of things come to my mind. I wonder if that heart was less compressed than this second patient. This patient, patient 1, had biventricular failure, left ventricular fraction at 17%. Eculizumab was initiated because of rapid decline in his status. Drug was obtained on a compassionate use basis. Again, this medication took longer, the patient took longer to receive it than my patient. Alexion at that time was giving it on a compassionate basis. In 2-3 days, his LVEF increased from 17 to 57%. And after 3 cycles of eculizumab, the patient was already going home. He remains on eculizumab. It's been 8.5 years. He hasn't had any major cardiovascular issues, no recurrence of symptomatic pleural or pericardial disease. But within the first 18 months after hospital discharge, he needed a readmission for abdominal adhesions and color perforation. He had fibro-obliterative vascular changes. There was no evidence of C5b9 deposition, which eculizumab, I think it was working. Subsequent, he developed malabsorption, wasting syndrome. He needed TPN. And I'm going to jump to the patient too, a little bit of his description. He was a 17-year-old male seen in 2009 with a 2-year history of skin lesions on the chest and limbs. He developed some crampy abdominal pain, then acute abdomen. At surgery, which his slide was presented by Dr. Magro, the bowels, he had hundreds of lesions consistent with MAP, malignant atrophic papulosis. He didn't have perforation, but there was an area when I talked to the surgeon that looked non-viable, and because she knew the medication was coming, she decided to leave it intact. Later, after the medication was given, that area looked vascularized, healthy, so he never needed any resection. But there was an area that almost got resected because it looked ischemic. As I mentioned, the wound couldn't be closed, and he was fully decompensated. He received eculizumab on the compassionate basis as well. He had immediate improvement with resolution of the fever, tachycardia, decreasing swelling of the bowels. It was very impressive, and he was his abdominal cavity was closed within 10 days. But unfortunately, as the patient number 1, he also progressed. This is him doing a sit-up. He had won a sit-up competition at his school, maybe the year before I met him. So he was very athletic. Within 1 year of initiation of eculizumab, he developed bouts of abdominal pain. Again, he required bowel rest, TPN, also developed gross hematuria. The cytoscopy showed suspicious lesions consistent or for MAP. He had also aphasia, numbness around the mouth and areas around his face, numbness in one arm, and an MRI showed some abnormalities. They immediately called me and they told me the patient had vasculitis, but it wasn't vasculitis. Eculizumab peak and trough levels were adequate. We were measuring that. So he needed something else. So now, what are the eculizumab limitations? Delay in access, as I already mentioned. Not every patient has been able to get it throughout the world as quickly as these 2 patients that I just mentioned. We can no longer obtain it by compassionate use. And at the moment, there are no ongoing sponsored studies. And we need to convince and persuade the insurance companies to give it to us. And it does not alter large vessel obliterative fibrointimal arteriopathy or myofibroblast activation. Evidence of interferon signal is not altered. Perivascular inflammation and mucin deposition is not altered. And this is what we're seeing in my patient or our patient. So there's some limitations with eculizumab as well. So we cannot be used as monotherapy. Multiple reports. So these 2 patients are not the only ones who have seen eculizumab. Several other patients have used it, and it has been unsuccessful. These are some publications of failures with these medications. You can see them there. 3 of these reports were 4-year-old with CNS disease. And there are some other multiple unpublished treatment failures. So we were thinking that maybe eculizumab does not reach the central nervous system. That's one of the theories. 2 of the published reports did not report transient stabilization or improvement in CNS disease with eculizumab. And that's the data. Just as patient 1 and 2, they showed evidence of disease progression. So I think because of maybe time limitations, I'm gonna tell you what I remember from this, because I read the slides. So Dr. Shapiro had this patient with scleroderma and pulmonary hypertension, which you probably heard, and she had classical skin lesions that look like Degos. He actually called me and said, could you look at this patient and confirm with me if they look like Degos or not? I did see the patient, and I concur with Dr. Shapiro that they look like Degos. Eventually, the patient went on treprostinil for pulmonary hypertension, and her skin lesions cleared up. Based on that, we started my patient on treprostinil. At that time, he had the aphasia and the possible CNS involvement and the MRI. The radiologist had called me that the patient had vasculitis. And I want to say probably about a month after that, we repeated the MRI. The symptoms had subsided and the lesion was gone. So the patient then, that's him, very happy and healthy looking, was now on the 2 medications. And then the first patient went on treprostinil because of our experience with my patient. Unfortunately, he kept telling me that he was having cutaneous reactions from the insertion sites. And around that time is when I mentioned the treprostinil came by mouth, and we switched him to the by mouth medication. And that's how the skin reactions look. They were indurated, very painful, very uncomfortable. Let's see, what else? So treprostinil. So we now follow 4 patients on combined treprostinil and eculizumab, 3/4 with persistently stable disease, 3/4 on subcutaneous regimen, 1/4 on oral therapy. There are 2 published reports of treatment failures, but these patients were critically ill at time of initiation of therapy and survived only a few weeks. We're still investigating the mechanism of action, but we just heard a beautiful presentation on this, so I'm gonna move on. So is there a place for tocilizumab here? And there are some reports that you can see there. Interleukin-6 receptor antagonist does penetrate CNS and may block endothelial cell apoptosis, which is promoted by IL-6, and may also increase population of endothelial progenitor cells. So we need another agent in addition to these 2. And we're brainstorming, and I guess the door's open for other options. Remaining issues. Disease pathogenesis remain obscure, so treatment are downstream from primary event. No single drug appears effective long-term, nor universally effective. Patients often are first treated at a point of very advanced disease. In the ICU setting, greater awareness of Degos, MAP, it's obviously needed, and we need to find a way of diagnosing these patients earlier and define who's going to be treated more aggressively and how should we treat the ones that we think are cutaneous, and how are we going to confirm that they're cutaneous only. My patient has a sister. The sister has Degos, cutaneous, because of Dr. Shapiro's thought of monitoring, making sure these patients doesn't have any GI involvement. She had a laparoscopy and she doesn't have any GI lesions. It was very painless for her. She's a very young girl, and it was very painless for her to have and very reassuring for her. So remaining issues, pleuropericardial fibrosis has progressed despite ongoing eculizumab treprostinil treatment in one patient. Additional antifibrotic treatment may be required long-term. There are now multiple antifibrotic therapies. How do we make choice of most appropriate agent for use in Degos? Systemic Degos is too rare and with too many potentially serious complications for a double-blind placebo-controlled study, unfortunately. These medications cannot be accessed quickly. In some countries, access to care has proven impossible. And that's it. Thank you.
We have time for a couple of questions.
Thank you so much. How do you get the treprostinil for your patient?
Can
you repeat the question?
How was I able to obtain treprostinil for my patient? It was approved by his insurance. We were able, so we at our office, we have a pharmacy service. Her name is Dr. Farrell. She's excellent. So she helps us write letters to obtain medications for off-label use. So we were able to obtain it. We're very fortunate, I guess.
So I think that interferon alpha was mentioned this morning as one of the components. Any plans to use the anti-interferon alpha receptor 1 from the immune, which looks doing okay, although I don't think we have DNA. But as for lupus, any plans that
We've talked about it. We've talked about that one. We've talked about JAKs. We've talked about the IL-6. Honestly, I don't know where to go from here.
It looks like when you have all these spread lesions, it's very difficult to treat this disease. And you say that we have anti-fibrotic drugs, do they revert?
We don't know. So they use this medication that I have in mind that maybe it's in the first line of possibilities to use, the sirolimus. They use it to prevent cardiac transplant rejection. So I think it prevents more fibrosis. Will it reverse the fibrosis that he already has? I don't know.
So one stuff is very clear when you talk is that you have to treat very early.
Yes.
In order to avoid systemic issues. Otherwise, it's very, very difficult.
Yes. Yes. Once you have the fibrosis, I don't know how you can reverse that. So yes, we have to be very aggressive since the beginning, I think.
Question over there.
So with patients that are on treprostinil already and Solaris, and they have progressive disease, is there an opportunity to increase the treprostinil?
It can be increased, and we have increased it. There are some limitations as far as the dynamics of the heart, so it has to be monitored by cardiology and pulmonology.
So if there are no more questions, thank you very much.